There is a building in your city. You have probably driven past it. Maybe you have been inside it. It was built sometime before 1910. You can tell by the brick, by the proportions, by the way the windows are taller than they need to be for a building of that size. If you go inside and look up, you will find something that no hospital built after 1950 has. Not a machine, not a medication, not a technology that was lost or forgotten. A design, specific angles, specific orientations, a specific placement of openings that were drawn into the original blueprints by architects who understood something about the relationship between buildings and human biology that modern medicine stopped teaching. And at some point, in the middle of the last century, that understanding disappeared. Not because it was proven wrong, because it could not be sold. This is the story of what those buildings were designed to do and what we decided without a vote, without an announcement, without most people noticing that we no longer needed. In 1854, a 34-year-old English woman named Florence Nightingale arrived at a military hospital in Scutari, in what is now Turkey. She had been sent by the British Secretary of War to manage nursing care for soldiers wounded in the Crimean War. What she found when she arrived was not a hospital, in any meaningful sense of the word. It was a converted barracks, dark, overcrowded. The sewage system ran directly beneath the wards. Soldiers who arrived with treatable wounds were dying, not from the wounds, from the building. Nightingale did something no one in military medicine had done before. She measured it, not the wounds, the building. She tracked mortality rates ward by ward. She recorded which patients were near windows and which were not. She documented the direction each ward faced, the hours of direct sunlight each bed received, the movement of air through the space. The wards with cross ventilation and direct southern light had mortality rates that were documentably and consistently lower than the wards without them, not slightly lower. In some cases, the difference between most patients surviving and most patients dying. The building was killing them, and she proved it. She published her findings in 1859. The book was called Notes on Hospitals. It contained specific, numbered architectural specifications for how a hospital should be built. The orientation relative to the sun, the height of ceilings, the placement and size of windows, thus the distance from each bed to the nearest source of natural light. She was not writing poetry. She was writing a technical manual based on documented mortality data for how to construct a building that would keep patients alive. The architectural world listened. Between 1860 and 1910, the Nightingale Ward became the dominant model for hospital design across Britain, the United States, and most of Western Europe. Long, narrow wards, windows on both sides, reaching nearly to the ceiling. The building oriented so morning light enters from one side and afternoon light from the other. Every patient receiving direct sunlight for some portion of every day. The mortality rates in these hospitals were lower than anything that came before. The architects knew why. The physicians knew why. And then, in approximately 20 years, between 1910 and 1930, the model was abandoned. Not because it stopped working. In 1908, the Carnegie Foundation for the Advancement of Teaching commissioned a study of American medical education. The man they hired was named Abraham Flexner. He was not a physician. He had no medical training. He was a school administrator from Louisville, Kentucky. He spent 2 years visiting every medical school in the United States and Canada, all 155 of them. In 1910, he published his findings in a document that became known as the Flexner Report. The report was blunt, damning. Many of the schools he visited were genuinely inadequate, underfunded, understaffed, operating without proper laboratory facilities. Some of them were dangerous. The Flexner report identified real problems. This is not disputed. What is also not disputed and is documented in foundation records that have been publicly available for decades is what came next. The Carnegie Foundation that commissioned the report maintained financial connections to a network of industrialists with wrecked interests in a specific model of medicine. John D. Rockefeller had, by 1910, invested heavily in pharmaceutical manufacturing. His advisor, Frederick Gates, had written a memo to Rockefeller in 1897 describing medicine as a field ripe for standardization. These are not allegations. They are in the archive. The Flexner Report recommended reducing American medical schools from 155 to 31. It recommended that remaining schools adopt a curriculum centered entirely on laboratory science and pharmaceutical intervention, what it called regular medicine, a term that specifically excluded practices not centered on patentable treatments. Within 20 years of publication, 120 of the 155 medical schools had closed. Our funding consolidated behind institutions that followed the Flexner model. And the Flexner model did not include architectural specifications. It did not include light. It did not include orientation. It did not include the careful relationship between a building and the biology of the people inside it that Florence Nightingale had spent 20 years documenting. Those things could not be standardized in a curriculum. They could not be bottled. They could not be prescribed. And so they were not taught, not because someone decided to remove them. Through the simpler, more durable mechanism of funding, the schools that received the money taught what the money wanted taught. The schools that taught the things closed. And within a generation, the knowledge of what a building could do for a patient existed only in the buildings themselves, still standing, still oriented correctly, still letting in the light, with no one left who was trained to explain why. In 1984, a researcher named Roger Ulrich published a paper in the journal Science. The paper was called View Through a Window May Influence Recovery from Surgery. It was not theoretical. Ulrich pulled the record of patients who had undergone the same surgical procedure, gallbladder removal, over 9 years at a suburban Pennsylvania hospital. He matched patients by age, weight, sex, and smoking status. He separated them into two groups. One group had rooms with windows facing a small stand of trees. The other group had rooms with windows facing a brick wall. The results were not subtle. Patients with the tree view had shorter hospital stays. They received fewer negative evaluations in nurses' notes. They took fewer strong analgesic doses. Same procedure, same hospital, same surgeons, same medications, different window, different outcome. The paper was published in Science, one of the most rigorous peer-reviewed journals in the world. It generated a field, environmental psychology, evidence-based design. 40 years of research confirming, in controlled conditions, what Florence Nightingale had documented with mortality statistics in 1859. Light matters, view matters, orientation matters. The relationship between a patient's body and the physical space it inhabits is not incidental to recovery. It is part of recovery. In 2005, a Swedish research group published a study of patients recovering from heart surgery. Patients whose rooms contained nature views had lower post-operative anxiety and required less pain medication. In 2008, the Journal of Advanced Nursing found that patients in rooms with more natural light reported less pain, took less medication, and showed lower perceived stress. In 2012, a study of a Belgian psychiatric facility found patients in sunlit rooms had hospital stays that were, on average, 3.67 days shorter than patients in darker rooms. The research exists, published, peer reviewed, not disputed, describing something the architects of 1880 already knew and built into every hospital they designed. The knowledge did not disappear, it retreated into the buildings, and the buildings have been quietly confirming it ever since. To the researchers who went looking, and to the patients who recovered faster in them without ever knowing why. The hospital is where this story is most legible. The mortality data is there. The architectural specifications are published. The Flexner report is a public document. The financial connections are in the archive. But the hospital is not where the story starts. Even the relationship between built environments and human biology is older than the 19th century. Medieval monastery hospitals, the infirmaries that cared for sick monks, were consistently built on the eastern wing of the complex, oriented to receive morning light, positioned near water, separated from the main population by gardens designed to provide both visual relief and medicinal plants within reach of recovering patients. The architects of these buildings were monks, not physicians, but they were working from an accumulated tradition of observation that understood, without laboratory confirmation, that what surrounded a patient affected what happened to the patient. Florence Nightingale did not invent this knowledge. She measured it and published it at a moment when measurement was the language modern medicine understood. She gave the old knowledge new credentials, and then the institution that accepted her credentials decided 20 years after her death that the credentials it needed going forward were different ones. Consider what was standardized out of existence between 1910 and 1950. Not just light, not just orientation, sound. The pre-1910 hospital design literature is full of specifications about acoustic separation, materials that absorbed rather than reflected the sounds of distress from adjacent wards. The research on noise and recovery follows the same pattern as research on light, documented in the 19th century, abandoned in the 20th, rediscovered in the 1990s, confirmed by peer-reviewed studies in the 2000s. Proximity, the distance between beds, the size of space around each patient, the presence or absence of private enclosure. These were documented variables in patient outcome, not aesthetic preferences. Every one of them required a more expensive building. Every one of them resisted standardization. Every one of them was incompatible with a model of medicine that needed to scale, to build hospitals fast, fill them with patients, and move those patients through a system organized around intervention rather than environment. The modern hospital is extraordinarily good at what it was designed to do: emergency intervention, surgical precision, pharmacological management of acute conditions. What it was not designed to do is what the buildings before it were designed to do: recover in. The old hospitals are still there, not all of them. Many were demolished to make room for the institutions that replaced them. But enough remain that you can find one within a few hours of where you are sitting right now if you know what you are looking for. They were converted into apartment buildings, into office complexes, into condominiums marketed as historic loft spaces whose original purpose the listing descriptions do not mention. The people who live in them report consistently something they find difficult to explain. The light is different. The space feels different. There is something about the proportions, the ceiling height, the window placement, the way the morning comes through at an angle that fills the room without glare. That is unlike anything they have lived in before. They are not imagining it. The buildings were designed by people who understood that the relationship between a human body and the space around it was not decorative, it was functional. And the function was health. There is a former Nightingale ward in a converted hospital in Manchester, England. Now, luxury flats. The estate agent's descriptions mention original Victorian features, an exceptional natural light. They do not mention that the exceptional natural light was calculated to the hour, that the windows were positioned to ensure every occupant received direct sunlight for a specific number of hours per day, based on research showing that amount of light produced measurably better outcomes in recovering patients. The knowledge that produced the light is gone. The light remains, falling through windows placed exactly where they were placed for reasons the building cannot explain and its current occupants do not know. I am not arguing that sunlight is a substitute for surgery. I am not arguing that orientation is more effective than antibiotics. I'm arguing something simpler and, I think, harder to dismiss: that there was a body of knowledge accumulated across centuries, documented with precision in the 19th century, confirmed repeatedly by peer reviewed research in the 20th, about what buildings do to the people inside them. That this knowledge was economically inconvenient for a specific model of medicine that emerged in a specific decade with specific financial backing, and that the mechanism by which it disappeared was not dramatic. It was not a burning, not a single decision, not a meeting where someone chose to remove it. It was a funding shift. The schools that received the money taught what the money wanted taught. The schools that taught other things closed. And within 20 years, an entire generation of physicians had been trained without ever being asked what a building does to a patient. The buildings still know the answer. The Nightingale wards, still standing in converted hospitals across Britain and America, still orient their windows the same way they were oriented in 1880. The morning light still enters at the angle it was designed to enter, the research confirming what that light does to a recovering body has been published and available for 40 years. The next time you pass one of those old buildings, the ones with the tall windows and the careful proportions, and the brick that has been standing longer than anyone alive can remember, look up at the windows. Ask yourself what they were designed to let in. And ask yourself what we decided somewhere in the middle of the last century. that we no longer needed. The buildings remember. We chose to forget.